Someone say professor? Okay, anyways, I won't cover them all today. I'll probably cover, I go from proximal to distal, but just to list all the bones on the board. Clavicle, scapula, and I only have the right side up there, but you have a left side. So for the appendicular skeleton, you do have to worry about right and left. So I'll put a 2 next to the clavicle and the scapula because you have 2 of everything. Okay, you have a left and a right. You have a humerus. And then to go back up, the clavicle is your collarbone, as it's commonly called. The scapula are your shoulder blades. And the humerus is the bone of the arm. Remember, in anatomy, the brachium is the arm, or the region between the shoulder and the elbow. Then you have the forearm, and there's 2 parallel bones there. There's the radius and the ulna. You have 2 humerus, 2 radius, 2 ulna. And the bones of the forearm, in anatomy we say antebrachium. When you get past the forearm, you get down to the wrist. There's little bones down there, you'll see when we get there. Carpals. You have 8 in each wrist, so for a total of 16. And then the bones of the palm of your hand are the metacarpals. And you have 5 in each hand, 1 that attaches to each digit. So 5 in each hand for the metacarpals. So for a total of 10, 5 per hand. So just think palm of your hand. And then for anatomy, the word for fingers is digits. And you have 3 small bones in these 4 fingers. So 3, 6, 9, 12, and then 2 in the thumb for 14. So you have 14 per hand, and that's 28 total. Now those individual bones of your digits are called phalanges. So you have 28. And those are just listing all the bones of the upper extremity. When you study bones of the appendicular skeleton, you are responsible for left and right. L and R, as we say it. So for example, okay, left and right. Well, they're the same, aren't they? Well, left and right aren't quite the same, are they? They're mirror images of each other. For example, if I highlight the scapula, the one on the left side and the one on the right side, to hide the others, I mean, could you tell which one that is versus that one? They're mirror images of each other. They're the same, but a mirror image of each other. Okay? And I only teach usually one side. When I present one side or the other. You are expected to know both. And what you notice in your study guide is I don't list left and right separately. I list the scapula once, and I put a 2 next to it. So what does that mean? It means you got to know both of them. Okay? You are responsible for left and right. Yeah, one time I had a student spread a false rumor about me. They said I don't teach all the bones, and that's not true. I teach them all. I think they were just confused. They didn't realize I just didn't list it twice. I didn't list left scapula and then right scapula because it's the same thing. I do teach all 206 bones, so don't be spreading false rumors about me. You're going to wish I didn't teach them all. But if you stick with it, you'll appreciate the knowledge you gain, of course. Now, the first two bones I'll teach are what are called the pectoral girdle. Sometimes also called the shoulder girdle. A girdle is a word that means belt. So let me highlight just those two bones, clavicle scapula, your shoulder girdle. I'll do multi-select. So there's the pectoral girdle on one side, the right side. You can kind of see those two bones, the way I have it looking kind of overhead a little bit. They start in the front, the clavicle does, and it articulates with the scapula, then it goes around on the back. So clavicle, collarbone on front, it wraps around back, forming an incomplete belt with the other girdle on the other pectoral girdle on the other side. If you look at the shoulder blades posteriorly, well, they don't connect. The shoulder blades rest on your thoracic region, but the shoulder blade on the left doesn't articulate with the shoulder blade on the right. Okay. And so it's kind of an incomplete girdle, as is described. And the advantage of that is this arrangement of bones, as it attaches to the upper limb, it allows for increased movement. Let me write that down. So the thought is that the pectoral girdle incomplete girdle, basically meaning it allows for that structural thing where the scapula don't articulate with each other. The scapula, hold on, I spelled that wrong. Scapula. Don't articulate with one another, allows increased movement. And that's good. The good thing is more movement. The bad thing is that they say that the shoulder is less stable because it can move more, which means it's less stable. More prone to dislocate. Let me show you what I mean by increased movement. For example, okay, I'm going to throw on the muscles here, but I want you to pay attention to one structure that's on your study list. See that inferior angle right there? Watch that as the shoulder girdle can move. I'm going to highlight the deltoid. I'm going to make it move the shoulder. Full-on abduction. So this movement is called abduction at the shoulder or the arm. And as you bring your arm, you can fully abduct it a total of 160 degrees. And as the arm extends, as it abducts, the inferior angle actually can move out. because it's not attached to the other shoulder blade. So do you see how that inferior angle is rotating? So that's what I'm thinking of when I wrote this notation for you, increased movement. You can have inferior abduction of, you can have abduction of the inferior angle of the scapula for a full 160 degrees of abduction. Let me write that down.
So is that what causes your shoulder to tear? Like
Causes what to tear?
your shoulder to tear?
Yeah, that's one of the things. Like for example, it's baseball season, so when pitchers, the throwing motion of a pitcher, you can tear those rotator cuff muscles because of the rapid movement of the shoulder blade. So, abduction, abduction of the inferior angle of scapula allows a full 160 degree abduction of arm. At the shoulder. So the correct way to name this movement is abduct arm or abduct at shoulder. You can kind of name the joint that's moving, or, you know. Well, anyways, for example, I mean, that movement, can you abduct that much with your lower extremity? Can you make the side of your foot touch your ear? No. Because the pelvic girdle is a complete girdle, there's not as much mobility. So that's the main advantage of the shoulder girdle, those two bones, clavicle and scapula. And you have more mobility in the shoulder. So let's just kind of start by looking at that first bone, the clavicle. That's kind of what it looks like from a superior view and how it articulates with the trunk to the arm. The clavicle is really important. It's the only bone that attaches your upper limb to the trunk. Of course, there's a lot of muscles that help stabilize the upper limb to the trunk, but this is the only bone that does it. Notice the shape. It's not a straight bar. It kind of is S-shaped. Right? Basically, when you study this bone, study it disarticulated, but also come and take the clavicle bone and walk up to one of our skeletons and see how it fits in the skeleton. So there's two ways to study bones, kind of like how you were studying the vertebra. You could study an individual vertebra and try to figure out which region it is, but you kind of also studied it in the strung up ones, right? So we're learning how to study bones disarticulated. And when it's disarticulated, be able to ID the bone, name it. Oh yeah, that's a clavicle. Yeah. But also know, is it left or right? Okay. And to help you to make sure, check yourself as a student, so you're not at an anthropological dig site doing archaeology. Maybe you're just in this lab, you're learning. Compare it to our bolted-in skeletons. See how it is articulated in the skeleton, so you kind of know it. On your practical, I'm just going to have the disarticulated bone just laid out there. I may have you identify a surface feature. You know, or I just kind of may say identify this bone. be sure to put left or right. You know, one time I did that, and the student just put left for the answer. They didn't name it. So, oh, that's pretty important too. Gotta do both, right? If I just say surface feature, you know, head of humerus, the greater tubercle. Because it's not enough just to know the names of the bones. You have to be able to tell left or right, but there's all these surface features, so you can tell proximal from distal, the front from the back. For example, for the clavicle, let me isolate it for you. Just that bone by itself, it's just laying on the desk, you pick it up, you have to orient yourself. The clavicle, I would say, can you tell medial from lateral? Well, let me go this way. Here, that's the medial end. Look at the shape of that head on versus that. That's the lateral end. So we call the medial end the sternal end because it's the part that attaches to the sternum. So that's what I have on your study sheet. Can you tell the sternal end from the other end, the acromial end? That's what I have on your study list. Let me make sure, yeah. Because the sternal end is medial, and that will articulate with the manubrium of sternum. We learned the manubrium when we learned the thoracic cage. Let me put it back in the full body. The name of this joint where the manubrium articulates with the sternal end of the clavicle is called the sternoclavicular joint. Forms sternoclavicular joint. Sometimes I just may say SC joint for short, but you should know how to spell that out, sternoclavicular joint. So the articulation of the upper limb to the trunk. And that bone, the acromial end, that right there, what I have zoomed in is the acromial end of the clavicle articulating with the acromion of the scapula. So I'll say lateral, where the acromial end articulates with acromion. Okay, that's of the scapular bone. And that forms the acromioclavicular joint. Now that joint for short is referred to as the AC joint. I see that term a lot. There's a lot of ligaments holding these joints together. For example, well, they just call it the sternoclavicular ligament, right? Holding that joint together. Now, some that I want you to know are on this side here, because they're prone to rupture and sprain. For example, that one is the acromioclavicular ligament. You should note that one. I want you to know that one. Acromioclavicular lig, short for ligament. Some other ones. That one right there, highlighted in green, is a ligament between the coracoid process of scapula to the acromion. So it's called the coraco-acromial ligament. Coraco-acromial ligament. Well, I'm here at the board, I'll just write it. There's another one that goes from the coracoid to the clavicle. There's a few of them, and they're called coraco-clavicular ligaments. Coraco-clavicular ligament. So let me highlight that one, going from the coracoid to the clavicle. Right there. They call it trapezoid ligament because of its shape, but it's part of what's known as coraco-clavicular ligaments. And here's another one there. Going from the coracoid to the clavicle. They call that one conoid. Okay. So I had you note these. When you know these, they're not on your study list for your lab practical, but you should at least know them for the lecture exams. These are prone to rupture. For example, hold on, let me get the sound going here. Here's a grade 1 dislocation of that joint.
The acromioclavicular joint is a joint in the shoulder that connects the clavicle bone to the acromion of the scapula bone. This animation demonstrates a grade 1 type of acromioclavicular joint dislocation. The dislocation is localized to the acromioclavicular joint without sprain of the surrounding ligament.
So in a grade 1 sprain, this one was sprained but not ruptured. Okay, you can go all the way to grade 3. I'll just give you an idea. There's an AC joint dislocation, grade 3.
The acromioclavicular joint is a joint in the shoulder that connects the clavicle bone to the acromion of the scapular bone. This animation demonstrates a grade 3 type of acromioclavicular joint dislocation, which is a severe type of dislocation. It involves subluxation of the joint via forceful impact to the superior aspect of the acromion, as well as rupture of the acromioclavicular and trapezoid ligaments.
Yeah, so that one looks like it did rupture this one as well. Okay, didn't look like the coraco-acromial one ruptured, but basically a typical injury is like you fall on an outstretched hand. The force is transmitted all the way up here. So those were like grade 1, grade 3 AC joint dislocations. To give you an idea why it's important to study these, important clinically. And we'll talk more about that later. I want to move on from the AC joint ligaments. I want to re-isolate the bone. One last thing to mention is, if you're going to be able to tell left from right, you have to be able to tell superior from inferior. So I put one feature. It's called the conoid tubercle. It's on the inferior aspect. It's that little bump highlighted in green. Okay, it's toward the acromial end. But if you can locate that bump on the bottom, you can tell the superior from the inferior aspect. So if you can tell top from bottom, medial from lateral, you'll be able to tell if it's the left or right clavicle. So note the conoid tubercle we ran down. It's on the inferior aspect of the clavicle. my next bone, the scapula. Shoulder blades on your back. It's on your backside basically, and let's see. Let me throw on the skin. You see how you kind of look from the inside, see the scapula pushing against the skin? And on your study guide, I put a couple of surface features that you can palpate. You can feel it through the skin. And for the scapula on your back, you can usually feel this medial border and this inferior angle. Okay. So I listed those as surface features to know, since you can palpate them. So let's kind of get it out of the body. Let me turn the skin off. Isolate this. So that is just highlighting the medial border. You can see why it's called medial, because it's medial. If you can orient yourself, you're off to a good start, especially when you're in lab practical and you have about a minute to identify something. So to orient yourself, this is the posterior aspect. Well, that will be lateral, and where the arm is. This is medial. And it's kind of shaped like a triangle, like 1, 2, 3 angles of a triangle. Know that inferior angle right there. Okay. So the scapula, it kind of goes, it's on your rib cage on the back. It goes as high as about, that is rib 3, that's the 3rd rib. And it kind of goes all the way down past the 7th rib on the posterior aspect of the thorax. So that's what I'm writing, on posterior thorax, around rib 3 to 7, close to that. You can palpate the medial border. And inferior angle. I'll say palpable structures. Let's see, other surface features. Study guide. You have the spine of the scapula. It's that big shelf that you see back there. There it is, highlighted in green. You can palpate that too. That's how I tell the front from the back. This is the posterior aspect. When I rotate it around to the front, you don't see it. Okay? That's the scapular spine, or spine of the scapula. The spine of the scapula, as it continues laterally, it kind of widens and flattens, and that part is actually the acromion. You can just call it acromion or acromion process, as it's known. And well, the acromion process, as you can see, is basically extends. It's a continuation of the spine laterally. There it is, highlighted in purple. Okay, just continues on from the spine. That's what the scapula looks like from a lateral view. That's what the acromion looks like from a lateral view. The acromion is commonly confused with the next process, the coracoid process. It kind of looks like a bird's beak. That's usually how I describe it. Orange is highlighted in purple. That's the coracoid. More or less, the coracoid is in front and the acromion's more posterior. But anyways, the coracoid process is an important attachment point for muscles. So those are three muscles that are attaching to the coracoid process. Well, let me explode it. Okay, well anyways, those three muscles are, well you might as well write them down now because they're on your study list too when we get to muscles. An attachment point for and let's remember when I use the word attachment, you should know that muscles attach to bones of your skeleton to move your skeleton. That's why attachments are important. Well, anyways, this is a bony attachment for the short head biceps brachii. A muscle called coracobrachialis. And the pectoralis minor. Well, just list them for now. When we get to muscles, we're going to study all of them. So I just want to continue on. Today's a bone lecture. Okay, exit that. All right, coracoid process done. There's these fossa. I'm going to isolate it again. What's in green, that whole bottom part is highlighted in green. But when you get the bone in your hand, you'll see that it's kind of like curved in. Fossa means depression. That whole green area on the backside is called, what's the infraspinous fossa? Infraspinous fossa. And this is an easy one to remember because infra means inferior to the spine. So it's the space right below the scapular spine. So if what I have highlighted in green is the spine, if the purple area below it is the infraspinous fossa, what is that light purple area above it called? The supraspinous fossa. Inferior to spine. superior to spine. So do you see how, like, this is the posterior view of the scapula? But appreciate there's another, the other side. Like, you know, imagine, don't imagine, I'll just do it. So it's like, I got Mr. Skeleton here, and I'm putting my fingers on the other side, underneath. So they call the other side subscapular. You see why it's sub? Because it's like my fingers are underneath. That's where you gotta put them. All right into your subscapular fossa. Here it is, highlighted in green. It's just basically that whole front side. Okay, because when it sits on the back, that becomes subscapular fossa. That is the anterior aspect of the bone. Now the reason why I put these surfaces on your study list, the rotator cuff muscles attach here. So do you see how there's three muscles filling those spaces? We'll learn those muscles as, well, for infraspinous fossa, the muscle in there is infraspinatus. In this supraspinous fossa is supraspinatus. And then subscapularis. Fill those spaces. They form a cuff around the shoulder. Oh, Lindsay was asking earlier, can you tear those? Like, yeah, those are the ones I commonly tear when you like move the scapula a lot and rotator cuff muscles. That's not even all of them. There's that one down there. But anyways, I'm going to move on from that. Know those fossa and know the muscles that kind of like attach there. Those are important for shoulder stabilization. Okay, let me go back to the major parts here. You have the glenoid. Where's glenoid? Come on. There it is. What's in green is the glenoid. It's a very shallow socket for, it receives the head of the humerus. People call it the glenoid, or they more aptly describe it as the glenoid cavity, a shallow socket that receives head of humerus. Well, anyways, the name of that joint is glenohumeral joint. When people say shoulder joint, typically they're referring to this one. But what we're learning today is the shoulder has many joints, not just that one. So right there, that half ball near the head of the humerus is fitting in the glenoid. That's the glenohumeral joint. There's many glenohumeral ligaments stabilizing that joint. I'll just kind of throw it up here, glenohumeral ligaments. Anything that's kind of holding those two things together, just call it glenohumeral ligament. If you go deep enough, there's a very significant labrum. Labrum means lip. This is called the synovial membrane. Oh, let me where's that from? No, forget the labrum. We'll just go with glenohumeral ligament. It's not showing it to me now. I think what's a good thing to do is to keep track of all these 3 shoulder joints. So I'll just say on your half sheet that you're supposed to turn in, like you kept from yesterday, or not yesterday, but the day before yesterday to today, you got up to number 15, is that correct? So for number 16, name 3 joints of the shoulder. If you're like, what are the 3? Well, talk about it with your neighbor. Look at your notes. They're there. Don't even name the ligaments. Just name the joints. 3 of them. Oops. All right, so let's name them. One of the shoulder joints is right here, glenohumeral joint. The other 2 had to do with the clavicle, ACSC. Write them out in their full name. Technically, they're all shoulder joints. Okay. Let's see here. I remember I was a student learning anatomy, and I was watching football. It was a long time ago, when Drew Bledsoe was the quarterback of the Patriots. That tells you how old I am. Well, anyways, he went out of the game. They said he had pain radiating from the center of his chest. I was like, oh, he damaged the SC joint. And turns out, yeah, they said shoulder separation, right? So you don't have to know much to like, okay, you can figure out what's wrong with the person. All right, what I did, I was playing around. You guys are answering the half-sheet question. The next 2 structures are supraglenoid, infraglenoid tubercle. And I have those on there because a head of triceps and biceps attached there, and that's what I'm showing to you now. Let me pull back so you see what you're looking at. I just isolated biceps and triceps. Bis and tris. Supraglenoid tubercle. Well, if it's supra, is it going to be superior to the glenoid? Yeah. So right where this muscle is attaching, there's a little bump there. So if I tag anything right here, superior to the glenoid, I'm going for that little tubercle. That is the long head of the biceps brachii attaching there. Okay, the other one, the head of biceps right there, head of triceps, I'm sorry, attaching right there inferiorly. There's a little bump there called the infraglenoid tubercle. The long head of the triceps attaches there. So those are attachments for those muscles. We'll get to muscles right after bones, and the bis and the tris. Always put the full name in an anatomy class. Don't just say bi and tri, because for example, you have biceps femoris, so you always got to put brachii, because brachii means arm, and it's II. I guess that pluralizes it because you have two heads. So this word biceps means two heads. Seps is cephalos, which means head. So triceps means there's three heads. But anyways, the head that attaches to these tubercles are both the long head. So that's why those are on your study list. We're going to learn those heads. Okay. Any questions on scapula? Moving on to the next bone. Moving on from shoulder blade to humerus. The humerus on the right side. Don't forget about the left one. This is the one on the right. Try to orient yourself. If you saw this bone just laying on the desk, could you identify it as humerus? It is the longest bone, largest bone of the upper extremity. I'll go proximal to distal, starting with the head of the humerus. It's shaped like a half ball. There it is. The head of the humerus is in purple. It forms the glenohumeral joint. So there's a lot of things in anatomy that are called head. So you have to put head of humerus. If you're, IDing it on a quiz or on a lab practical, head of humerus, basically to describe it, it's a half ball. And as I said previously, it forms the glenohumeral joint. So in anatomy, it always goes head, then neck. The neck, what's called the anatomical neck, right there, highlighted in purple, that ring, it is just after the head, right? So if I point to kind of like, I'm going to try to label the head, I'll put it right on close to the top. So to be clear. So if I go on that side, I'm going for the anatomical neck. The anatomical neck, there's nothing to say about it, it's the neck. It comes after the head. And after the anatomical neck, you have those two bumps, that one there, I've highlighted in purple. It's a tubercle or tuberosity. They call it the lesser tubercle here. And the one next to it, posteriorly, is the greater tubercle or tuberosity. So let me put those terms down. tubercle means bump. Some books call them tuberosity. Both will be acceptable for you. Just choose which term you like to remember, and they both mean bumps, bumps on bones, tubercles or tuberosities. But there's a lesser one, lesser greater. The one highlighted purple is greater. It's bigger. Now, what you could do is, well, the rotator cuff muscles I mentioned earlier attach to those tubercles. Okay, the supraspinatus, infraspinatus, subscapula, those ones. So I'll just say as a note, rotator cuff muscles attach here. The thing about those two bumps, they create a groove right in the middle, highlighted in green, between greater and lesser tubercle. What's highlighted in green is, I call it the intertubercular groove. Intertubercular because it's in between the two tubercles. So, inter means between, intertubercular groove. This app is calling it a sulcus, same thing. A sulcus is a groove. This is also known as the bicipital groove, aka the bicipital groove is a groove for the long tendon of the long head of biceps brachii. There we go. So I'll just zoom in. So there you see the tendon of the long head of biceps in the groove, in intertubercular groove. Tendon of long head biceps brachii lies in this groove. What I've highlighted now in green, it's the second neck of the humerus. It's called the surgical neck. The surgical neck of humerus, as opposed to the other neck, the anatomical neck, the surgical neck is prone to fracture, hence the name. Because look where it is. It's kind of where the tubercles kind of narrow. That's usually where bones snap, right? Prone to fracture. The anatomical neck is called the anatomical neck because in anatomy, it always goes head, then neck. But this is a little further down. It's kind of a neck. So they call it surgical neck, prone to fracture. Like for example, we have a fracture tool on here. So like, that would be like what a fracture might look like. And it's dangerous because you have a very important artery and nerve that wrap right around that neck. So you don't want to damage that, do you? So let me get rid of that.
What's the common injury in that?
Fracture, just what like I've illustrated.
I mean, like how does that fracture be? How does the fracture happen?
Oh, I would say the same thing as the shoulder separation, just kind of fall in outstretched hand.
Okay.
Or receive a blow, like football, something,
Okay.
yeah.
Okay.
Receive a blow laterally. Oops, didn't want to do that. When I was in high school, I played soccer and track. I'm kind of glad I didn't play football. I wonder if anyone's ever played football and never got hurt. Very rough sport. Okay. I'm going to go to the midshaft. There's a little tuberosity there I want you to find. It's called the deltoid tuberosity. So what's highlighted in green? It's kind of like midshaft and it's lateral. This is the anterior aspect, so kind of turn it to the side. You can see that little green bump in the middle. It's the only surface feature that's kind of midshaft. So if I label anything kind of in the middle, I'm going for the deltoid tuberosity. Located lateral midshaft. Obviously, it's where the deltoid muscle inserts. The deltoid is your big shoulder cap muscle. It refers to the shape of the muscle, delta, the upside down triangle. So when you look at the muscle as a whole, it looks kind of like from the side an upside down triangle. And it's going all the way down and attaching laterally. So one thing about muscles and attachments, if you know where the muscle attaches, you can kind of tell what the muscle will do as its action. If the muscle pulls from the outside, can't you deduce that this muscle can abduct the arm if you pull from the outside? If the muscle pulls from inside and you pull the arm in, what do you call that? A deduction. And so you need to start thinking, when we get to muscles, I'll revisit that idea. If you know where a muscle attaches, you can deduce its action, okay? Anyways, deltoid tuberosity, that's where the deltoid pulls on the arm bone. Then we're going to go down to the distal humerus and look at the condyles. The trochlea and capitula. Let me highlight one. So we're going to go down to distal humerus, and we have two condyles. Condyles, the general term, like when people draw bones, like that, right? The condyles are the widened part, and in bones, the wide parts are good for articulating with the next bone. So the two condyles of the humerus are the capitulum and the trochlea. They'll help form the elbow joint with your forearm muscles. So what's highlighted in green is it's ball-like. It's called the capitulum. Now there's different spellings. That's the one I usually go with. The one in the atlas, they spell it differently. You could look it up. But that's the one I usually see, capitulum. The other one right next to it in purple, I'll just highlight it there in green. That's the trochlea. It's more like a pulley shape. That's what they look like in the front. Here's what they look like posteriorly. Capitulum and trochlea. The capitulum is ball-like. Trochlea means pulley. Trochlea is a word that means pulley. I just should have used that as how I describe it. The capitulum articulates with the radius bone of the forearm. Radius. The trochlea articulates with the trochlear notch of the ulna. Those are the main articulations of the elbow. Elbow. Let's see here, go back to full body, let's go. It's good to get these three bones and try to put them together. All our bones, they're mismatched. They're not necessarily from the same person, but you can still put them together. The ones that are the bone boxes, how they're all a bunch of bones in a box and they're labeled left and right, those have been matched pretty well. And what you can see is that just put them all together. That round ball should kind of fit in that head right there. This is the radius bone. This right here is the trochlea, and it fits with the notch of the ulna bone. The other thing is, and these are the last two things for the humerus, you have the coronoid fossa and the olecranon fossa. So this is the front side, the anterior aspect. I'm going to zoom in on that part that's in green. The fossa is a depression, and that little depression is the coronoid fossa. The reason why that fossa is named coronoid is when the forearm flexes, there's a little process of the ulna called the coronoid process that will fit into that fossa. Receives coronoid process. That's on the ulna bone. During forearm flexion. You know, on the back, there's a fossa called the olecranon fossa, right there, highlighted in green. It receives the olecranon during forearm extension. Coronoid fossa, olecranon fossa. So olecranon fossa in green, receives olecranon process. Oh, whoops, I misspelled process there. Pros. So the olecranon fossa receives olecranon process, that's also of the ulnar bone, during forearm extension. Let me show you what I mean. So just to give you a macro view, that you're flexing the forearm right there and extending it. So when I zoom in on the joint, when you flex, you should be able to see a little lip going right into that fossa. So what I was trying to say is the coronoid process is right there. And as you flex, it fits into that fossa in the front when you flex. Okay? And by the same token, when you extend, the olecranon fossa receives the olecranon. That's easier to see because the muscle's not in the way. So there's the olecranon fossa. When you fully extend, the olecranon kind of fits in that space when you fully extend. When you elbow someone, you're basically elbowing them with the olecranon, the bony part of your elbow there. But, all right, let me get out of there. Let me make sure I covered everything for the ulna. Oh, I missed a couple of things. Okay, the last two things for the ulna are the medial and lateral epicondyles. Medial and lateral epicondyles. So what I have highlighted in purple is the medial epicondyle, and that's another useful landmark because basically it's called medial epicondyle. If you're going to tell right from left, if you can tell which is the front and which is medial, then you'll be able to identify if it's left or right. Okay, and that's the medial epicondyle. Let me zoom in on it. It's just that big knob medial to the condyles. So that's why they're called epicondyles. They're right next to it. For the medial epicondyles, that's a big attachment point for a lot of forearm muscles. There's a lot of wrist and digit flexors that originate, that attach to the medial epicondyle. And then it's the same thing for the lateral epicondyle. Highlighted in purple now. It's not as knobby looking as the medial one. Well, anyways, there's a lot of wrist and digit extensors that attach to the lateral epicondyle. So I'll just say wrist and digit extensors attach here. I'll give you a sense of what that looks like. There's a lot of muscles here, but we're going to learn them all. But the basic idea is you can see muscles attaching to both sides, right? Is this side medial or lateral? This side, I know I've got to zoom in, this is medial. If this side is medial, there's the medial epicondyle. All these muscles attaching on this side, they're on the front of your forearm, they're flexors. And all the muscles attaching on this side are all extensors. So we'll learn those up. Let's take a break. When we come back from break, we'll go into lab.
Can we turn in the half sheet?
Oh yeah, go ahead. If you want, turn your half sheets over by the torso. So fairly. See the head of the humerus? How it's facing in? That's medial.
Yeah. Oh, okay. Yeah, that makes sense. So is the next quiz on Wednesday on this page only?
Yes.